Hello, everyone. Thank you for joining today's webinar, The Pathway to Success in 2021. Is your ACO on it? This webinar is sponsored by PointRight and Guidehouse. ACOs use PointRight's predictive analytics to manage care transitions, optimize population health, and improve total cost of care and quality. Go beyond CMS's Pathways to Success Accountable Care Organization 5-star requirements and achieve better outcomes by incorporating key benchmark metrics into your network. Guidehouse is a leading provider of consulting services to the public and commercial markets with more than 8,000 professionals in over 50 locations globally. Guidehouse's health segment includes a team of public health and provider administrators, clinicians, and other experts with decades of strategy, funding, policy, revenue cycle management, digital and retail health, managed care, and managed services experience. I'm Sharon from World Congress. I'll be introducing today's webinar. Just a few announcements before we start. I'd like to explain how we're handling questions. Due to the number of attendees, participant lines are muted. However, if you'd like to submit a question for our speakers, please do so using the Q&A feature that you see at the bottom of your screen. We'll answer all questions that we have time to address during our session today. Please feel free to contact our presenters with any additional questions you might have after the fact, and please note the webinar will also be recorded. You'll receive an email with a link to the video so that you can view it again. I'd now like to introduce our speakers for today. Sharon Fisher is the Chief Development Officer at PointRight. Dr. Brian Jones is Partner, Health at Guidehouse, and Lisa Trumble is President and Chief Executive Officer at SOHO Health. And now, without further ado, I'd like to turn things over to Sharon to get us started.
Thank you, Sean, and welcome everyone. Maybe we should start off with some good news for a change. So the good news is for the third year in a row, our ACO programs have achieved a net program savings. And in this most recent year, 2019, the largest savings to date of over $1 billion. So that's something to celebrate when there's not a lot to celebrate lately. We are seeing, evolving alternative payment models, right? We're seeing growth in managed Medicaid. We're seeing clinically integrated networks continue to expand in episodic bundles. To us on the call today, we all see these as, points towards the path of value and that it's really here to stay. So therefore, or I should say, we're also seeing some, very well documented that 75% of healthcare expenditure is consumed in chronic conditions. So therefore, we have many transformational strategies and multi-pronged approaches occurring at all levels within these organizations, whether it's change management or governance related issues and operations and clinical management. So many of these pieces need to come together so that we can achieve those ultimate savings and get the quality out of the program that you want. So the big question then is, how do you know if you're on the right path, right? So why don't we go ahead and next slide. Thank you. Well, one way to understand where you stand is to compare the performance of your ACO to another. But unfortunately, not all ACOs are exactly the same. There's 4 different structures on the screen in front of you. And, some of these elements you can choose, but it's important to understand the distinction when there's a macro numbers that are being reported, like the big dollar savings, and why am I not seeing the same savings in my area? Well, some things that you can't choose may be the location that you're in and the type of population that you have. So those are all very important when you start to look for ways to compare one against the other. Strategic choices you can make organizationally, operationally, and be able to execute on. It's going to be a big factor in your shared savings overall performance, right? And you're going to hear more about this from Brian and just a little bit our partners there at Guidehouse. I'm going to turn it over to Lisa though first from SOHO Health, and she's going to share with us, how this looks for 2 ACOs that she's led, and what those different structures and strategies were for each. But before we do that, we'd like to take a quick little poll so we understand a little bit about the strategies that you may have underway within your organization. So poll's going to pop up, I think, on your screen, and you can complete that now. Okay, let's take a look at this. Optimizing existing processes looks to be our winner, but there's a lot following in track. Taking on more risk, improving our, fantastic. Well, I think you're in for a treat today because we're going to be able to cover a lot of these things. And thank you for sharing this with us. Lisa, I'll turn it over to you now to share a little bit about SOHO and why you're choosing the path that you are on.
All right, thank you, Sharon. Hi, my name is Lisa Trumble, and I'm the President and Chief Executive Officer for SOHO Health, Southern New England Healthcare Organization. We're based in Massachusetts and Connecticut, and we're a clinically integrated network. For those of you who aren't sure what a clinically integrated network is, it's an aggregation of providers or multiple networks that are brought together for purposes of contracting and managing attributed lives. Our network has decided we're going to focus on population health. So we're taking a long-term view, a broader look at the population, and incorporating many things like social determinants of health into our framework for how we're managing patients. A little bit of context for this. I'm relatively new for SOHO. SOHO's relatively new. We formed on January 1st of this year. Who would have thought that would have been an interesting thing to do this year, but it is a new organization. We basically consolidated 3 ACOs, one in Waterbury, Connecticut, one in Springfield, Massachusetts, and one in Hartford. We are affiliated with the Trinity Health in New England Hospital System in both Massachusetts and Connecticut, and are currently responsible for over 200,000 covered lives. Our goal is to manage over 300,000 lives by 2023. We need to do that in order to balance our risk and in order to achieve the savings that we need in order to sustain our infrastructure. We are currently managing $1.5 billion in total cost of care, and we have 1,618 providers. I apologize for the background. 1,618 providers. We'll be at 1,900 providers by 2021, January 2021. Next slide. So what were our earlier challenges? As I mentioned, we started on January 1st, 2020. I'm a new CEO as of January 7th. We spent a lot of time trying to aggregate and build our new governance structure that incorporated the 3 different organizations that I mentioned previously, and to develop a strategic plan. This also required creating and fostering hospital and physician alignment and integration of people, data, technology from 3 different organizations and in 2 different states. And then aligning and restructuring our operations to support a more contemporary approach to population health. Really required looking at who's reporting to who, how are we structured, do we have the right people, do we have the right skills, do we have the right tools? And then addressing significant differences in the competitive landscape and value-based approaches between Massachusetts and Connecticut. Massachusetts and Connecticut, even though we share a border, we don't share a lot of principles in terms of value-based approaches or population health. I would say Massachusetts is far more advanced in that regard, and Connecticut is a little bit behind. We call it the land of frozen molasses in terms of our ability to actually move forward with value-based care. And then lastly, managing a number of disruptive entrants into our market, the Vera Health, new technology firms, Dispatch Health, Optum, et cetera. I'm sure you're all dealing with these types of influencers in your marketplace. And then the last thing I would say is the pandemic. Certainly, when I started on January 7th, I had no idea that I'd be facing a pandemic. It would need to rethink how our organization would operate in the throes of a pandemic starting in March. And then that took about 6 months for us to navigate our way through the pandemic situation and how our practices in hospitals were managing in our existing risk agreements, which today include about 40 different risk agreements that cover the 1.5 billion that I mentioned previously. And so now I'll turn it over to Brian to continue the conversation.
All right, thank you very much, Lisa. So my name is Dr. Brian Jones. I'm a family physician and informaticist by training. I'm a partner here at Guidehouse, and I really sit at the interesting intersection between federal healthcare and commercial healthcare. So I maintain a clinical practice as well as providing consultation services to the VA military healthcare system, as well as also practicing in a large nationwide payer provider organization throughout the in the DC area here. So how are healthcare systems, many of whom are facing some of the same challenges that Lisa outlined at SOHO, navigating these challenges in their efforts in establishing their own ACOs. So the example I want to provide today is Affirmate Healthcare Partners in Michigan, who's a physician-led, clinically integrated network who serve 49 counties throughout the state of Michigan. Their CEO, Dr. William Mayer, talks about the fire triangle in establishing ACOs. So remembering back to my Boy Scout days, if you're building a campfire, the fire triangle consists of fuel, heat, and oxygen. But if you're building an accountable care organization, there are 3 key elements he talks about that were critical to his ACO journey. The first element is data analytics. So having real-time, actionable data is critical to informing the clinical transformation required to not only building your ACO, but informing subsequent business decisions. They established dashboards, which enabled them to visualize everything from claims data to clinical data, and that provided a line of sight from the exam room all the way to the boardroom, while also informing things like population health strategies and improvement in physician decision support capabilities. The second pillar is clinical transformation, which is another key element in the ACO fire triangle. So data-driven performance improvement based on clinical best practices with the goal of really influencing behaviors in the exam room. This is really where I'm passionate about this type of work. Healthcare systems have made massive investments in electronic health record technology, and many have only scratched the surface in leveraging the full set of capabilities of the systems they acquired. By informing providers at the point of care with data from the local CINs, from the local health information exchanges, layering that on top of the most current clinical integrated evidence-based practices, we can help to ensure providers are uniformly making the best decisions clinically for their patients in the exam room, but also economically for the business across the ACO. So lastly, participation in the Medicare Shared Services Program through planned partnerships with local healthcare systems. So Lisa touched on this, and Affirmate led the creation of the Federation ACO, which comprised of 6 local healthcare systems, 21 acute care hospitals, and over 5,400 independent and employed physicians. The Federation ACO in 2018 was 9th in the nation for Medicare Shared Service Plan distribution, and they also have a projected $98 million in cost savings, $63 million in revenues, and are on track to achieve an astounding 375% return on investment within 5 years of establishing their ACO. So next slide. We're gonna go a little bit more in depth in thinking about developing a data-driven strategy. The Federation ACO in the Affirmate example was an amalgamation of 6 different healthcare systems locally in Michigan. Many healthcare systems across the country have grown organically through expansions in the market, but also inorganically through various acquisitions. And we've seen this across markets across the country. With those acquisitions, healthcare systems begin to accumulate disparate data sources in which many do not neatly interface with each other. This is a big challenge we've seen across the country. What we have found is that organizations have a lot of available data, but they don't have a robust integrated analytics capability to improve their data analytics IQ, or what we're calling data literacy. That we're going to define as having a set of capabilities that can be used to drive decision-making across your organization that does not require your entire staff to have a PhD in data science or have 15 different Excel sheets open up on their desktop to make heads or tails in terms of what the clinical and business story is of your organization. So the good news is that to achieve data integration and the eventual data literacy, your entire ACO does not all need to be on the same system. So with the commercial data warehousing capabilities available in the market, you can integrate your data sources for things like claims data, CMS pricing, EHR data, population health, layering into other data sources like local economic and social determinants of health data, and overlay them with visual capabilities like Power BI, Spotfire, Tableau, all commercially available to create that real-time actionable data insights required for the type of transformation that Affirmate made successful. Having this integrated data framework and analytics capability is the foundation of any clinically integrated network or ACO across the country as we stand these up. Next slide. So as we start to build out our strategy, the journey through growth objectives and ACOs could really kind of become clear. So new patient acquisitions make sense. Maximize care impact makes sense, and in-network care retention also makes sense. And it seems easy, right? Well, not quite. So there are some more granular steps that providers need to take on their journey to becoming a successful ACO. The good news is that there are repeatable processes for each of the methodologies below to solve these objectives. And I want to focus on one that's really kind of near and dear to my heart, which is the provider management section. So I have friends from medical school who went to various specialties that I hear from regarding ACO performance models, PCMH reimbursements that really skew toward primary care. So as I hear their feedback, I do take the opportunity to respond by saying, you know what, as a family doc, I'm not going to complain too much because that begins to to mitigate some of the salary discrepancy between me and some of my specialist friends. But the conversation does highlight some of the challenges ACOs have with incentivizing primary care versus specialty care physicians. So in October, we recently had our annual Guidehouse Clinical Integration Summit, which we're going to post the link in the chat box here. But I was inspired when I listened to Dan Broom, who is the Senior Vice President for Network Development of Emory University, talk about this very topic. So here's what Emory did to address this issue. Their physician board is comprised of 50% primary care physicians and 50% specialists, and he needed them to collaborate and come up with a solution on performance payouts to all physicians in their ACOs. What the group of physicians ended up doing and deciding is that all their performance bonuses will go to the primary care physicians. And I kid you not, and before you shake your head, what the specialists received in return were all those bonuses were incentives for the primary care physicians to utilize the decision support to, one, help them refer to the most appropriate cases to the specialist, and two, maximize the use of internal clinically integrated network resources. They weren't sending them outside of their direct care system in the CIN. This resulted in an uplift in the specialty bill rate and ultimate revenue because the specialists were seeing the most complex cases in their office, and they were not seeing cases that could have been easily handled in primary care if the primary care provider had additional information. So this incentive structure was really of interest. It worked for both the primary care communities and the physician specialty communities at Emory, and that was pretty exciting. So I also want to talk a little bit about service line strategies. So as organizations move to stand up in ACOs, the conversation around governance should really be first and foremost in the minds of leadership. So again, I spend a lot of my time in the intersection of very large healthcare systems like the VA and the military health system, and where there's always a constant state of flux in the governance process, even before you're talking about introduction of any conversations in regards to bringing in additional entities or healthcare organizations and standing up something like an ACO. You need to establish a representative governance structure that ensures that your stakeholders feel like their voices are being heard. Because as we talk about workflow optimization, as we talk about clinical transformation, there's a huge change management component that entails with this, especially if we're looking at standardizing some process across a CN or across multiple healthcare systems. So getting that buy-in through a representative governance process is going to really help really instituting some of the changes that we're going to be able to make as we stand up ACOs uniformly across the markets. So in terms of network development, I'm not going to dig too much into this here, but I do want to making sure that bringing in a robust network will allow you to achieve economies of scale with both the Medicare and Medicaid shared savings programs, and also decrease redundancies when you start to consider things like bundled payments. But Sharon's going to talk more about a data-driven collaboration in the network, particularly around post-acute care. So Sharon?
Thanks. Yeah, so the ideal post-acute network development, some of the strategies are, and the aims are obviously around a quality-focused collaborative. We want to have improved outcomes with reduced costs, right? And have some sort of standardized and best practice sharing that can happen across the peers. And to do that, you really need the data to be in a format that is, one, current, right? Two, you want it to be structured and standardized so that it gives the ability to be able to risk adjust, not just by looking at rehospitalization, but the ability to break down by those clinical cohorts, such as heart failure or COPD or pneumonia, et cetera, so that you can try to objectively measure performance between one nursing home and another. The only thing a nursing home has in common with another nursing home, when you start to take on this, you step out of the walls of the health system and you start looking at post-acute care, is a license to be operating as a nursing home. But the populations that are coming in and out of these centers are extremely different. So how do you compare one to the other? And by using descriptive and predictive analytics that we use and offer to our clients, you're able to then not only really compare performance, but you can also get to the level where you're managing those chronic care and high-risk populations way before you start to see it in the nursing home's EHR. And we'll talk a little bit about that in a moment. Next slide. So, what is the right data to use? Well, there are great use cases and ideally to support a combination of data. Our position is always, we're kind of better together, if you will. There are some nuances though. Hospital systems are very accustomed to looking at claims data. In the post-acute world, the claims data is so old, if you will, that it's you really can't take action on that data. It does, however, allow some nice directional trending, and historical trending is there's nothing wrong with that. There's also nothing in many data sets, like from CMS and such, that have these historical lag data sets. You can get some decent trending, but the only data set which is this minimum data set, which is a very unique assessment that happens in every nursing home across the country. It is standardized and it is a structured data set. And as you saw in one of Brian's slides, all those different data sets that you come together, the ability to leverage that current insights and then laid on top of that, the predictive models makes this an actual framework for any ACO or clinically integrated network to be able to take action at the patient level as well as understand performance across the network. So our experience has really shown that collaborative networks that are using the MDS data as one of their key elements to manage the performance in high-risk populations are seeing a much greater and sustainable improvement. And we can send out some case studies and such around that for you if you like. We can go to the next slide. There is a framework that we have created and we use, and many of our clients are using, because now once you have the data, how do you then build and optimize and manage this network? What do we do next? So we've created a framework for you. You'll have access to a strategic guide that we've written, and feel free to use that. You can come back to us with any questions that you have. But this transformational framework allows you to us to support you, whether you're just beginning fresh of building out a post-acute network as part of your strategy, or if you're kickstarting and relaunching one that may have gone stagnant, right? Or is there, or do you have a program and you've kind of plateaued and you're just not hitting the next performance measures and KPIs that at the rate that you had desired? So very quickly, I'll give you a quick overview of the 3 phases, and then we're going to find out from you kind of where you all are in your journey around this. So phase 1, if you're just getting started, if you're trying to reevaluate which nursing homes should I choose, which ones did I choose, how are they performing compared to each other? So we have tools around that help you do a competitive analysis of looking at geographical comparisons. And what is there a weakness in the overall region? I worked with an ACO who had 65% and more, or over 65% of patients that were, or residents, I should say, that were over the age of 65 had diabetes, yet there was only one endocrinologist in the city. And there were only 2 diabetic educators in the whole community. So it wasn't surprising that diabetes management was kind of regionally underperforming. So you can tease these kinds of things out. You can also find out the outliers of who are the high performers by a clinical condition, who are the underperformers, and you can start to kind of get a sense of what is the landscape of the market that you are managing your population. Then as we move into phase 2, this is where the KPIs that you want to use, and we can start to drill in and really measuring those risk-adjusted rehospitalizations. You'll hear Lisa in a little bit talk about, managing length of stay and looking at staffing, as well as quality measures of both the short stay and the long stay population, looking at discharging to the community. All those kinds of things are happening kind of in that second phase. And lastly, in the third phase is where you start to get a little bit more robust. And now this is where the predictive analytics and helps you down at the patient level. So if you are managing a population and patients that are moving through the continuum, you're going to want to have the confidence and a safety net to know, help you that if the length of stay that you're desired, is there going to be a safe transition, and are the right community-based services propped up for this patient? So there's a lot of rich predictive analytics that you can manage ahead of time and see ahead of time in your planning efforts. So there's so much more on this that we can go into, and all three of us could probably spend a day with you on these topics, but happy to send out the white paper or enjoy it after this or during the conference or afterwards. But why don't I turn it over to Lisa? She's going to walk us through the strategic framework that they've been putting in place. And just like we did before she goes, why don't we just take a quick poll, and love to understand, based on kind of these three phases, where are you, or have you started yet? So let's take a look at that. That's awesome. So it looks like it's almost a tie between getting not started yet. So that's good. We want to help you get post-acute, hopefully, into your strategic framework. And Lisa's going to spend a significant bit of information on why that's so important. And then it's great to see many of you are, in that early stage phase 2. So I'm hoping that you'll take a lot of tricks and tips away, and we'll be here to help you along your journey. Thank you. Lisa?
Thank you, Sharon.
Mm-hmm.
So why consider a post-acute strategy? It's good to actually see a number of you are trying to sort through this and figure this out, and wonder how all the connections are made within what Brian said in terms of governance and network management, and then what Sharon said in terms of the three phases of information and assessment that you need in order to perform successfully in your ACO, but also to perform successfully in the post-acute space. Next slide. So when you look at the healthcare dollar, and this is an illustrative example, it would vary by Medicare, Medicaid, programs, commercial. So the spend isn't identical across all of them, but just as an example, when you look at the SNF spend, it looks very small, right? It's a small amount of money when you look at it compared to inpatient spend. However, when you consider the impact that SNF has on every other category, it is not an immaterial spend. It is actually quite consequential to your overall performance. It impacts, if you have readmissions, if you have poor quality in your nursing homes, it impacts inpatient stays, it impacts your professional spend, outpatient pharmacy, etc. So I look at this as SNF is really key. It's a key component. It's not the only component, but it's a key component to being able to successfully perform in an alternative payment arrangement in your ACO. Next slide. So when you look at, not only look at where the dollars are impacted by a SNF strategy, if you look at what CMS is doing and what they intend to do over the next several years, you can see there are many strategies they're deploying. Those strategies all are intended to focus on increasing quality and reducing costs. But when you look at the areas of the purple circles, it shows where there are potential implications or a compounding impact of a poor post-acute strategy. So if you're not managing your nursing homes, your hospitals are paying in their hospital readmission reduction program. They're paying for it in their value-based purchasing strategies, and so on and so forth. So nursing homes are penalized, hospitals are penalized, physicians are penalized, your bundle payment programs are penalized for not managing this, what's considered a relatively small, impact on the dollar. You're penalized even more so in a compounded way when you're not managing that portion of the dollar well. Next slide. So when we talk about managing the population, what does that mean? And a little bit to what Sharon said, you need to understand your network, your infrastructure within each of the nursing homes, their skills, their capabilities. What populations can they take care of? What's the environment of care look like? If the environment of care is poor, then the outcomes may be related to that. So in a post-acute scenario, the spend is impacted both by the environment and in the healthcare dollars. If you could click the next slide, that would be good. So, the post-acute strategy is impacted both by environmental circumstances and the healthcare conditions that occur in a particular nursing home, what capabilities they have, what populations they can take care of. So in addition to understanding who can take care of CHF or diabetes, you also need to understand if they have core competencies in being able to manage certain outcomes related to disparities of care and certain social determinants. If you have a person who's homeless, can they manage a homeless person? In addition to having diabetes and possibly homeless, maybe there's additional serious mental illness that needs to be considered. Not all nursing homes have the skill or the capability to manage those types of populations or that complexity. And if you don't have the right tools in place to understand that about your nursing homes, then you're not informed in terms of where's the best place to place your patients when you're looking to discharge them from a facility. And the last thing I would say is the network constellation for your ACO is really important in this regard. You want to have a preferred network of SNFs that you know you can count on, that can manage the full range of complexity that you see in your population. And you're going to have other nursing homes that of course you might use, but that you wouldn't consider them preferred. So as Brian said, it gets to your network definition, and how you construct your network is really important to your overall ability to be able to perform. Next slide. So when we look at quality in a nursing home, and we want to produce quality outcomes because we know quality generates lower costs over time. It produces situations where you're less apt to have readmissions and other adverse events occur. So it's efficient and it's effective to make sure that you have quality first and foremost in your evaluation of your nursing homes. So when you're looking at a post-acute scenario, what information do you currently have available? Well, you have your usual and customary word of mouth. You have what you might have from claims data, which is readmissions, length of stay, admits per thousand. But what you get with a PointRight analytics tool is all this other information that Sharon explained comes from the MDS structure. This information is real-time, it's structured data. You are able to evaluate in a quicker fashion what's happening in any of your nursing homes before you even receive the claims data and understand that additional readmissions or an extended length of stay may have occurred. Next slide. So when you look at a successful population health strategy, as Brian mentioned, governance is really important. Having the right people involved in your governance structure, having the right governance structure is really critical to being able to move your network forward and to generate the outcomes that were communicated earlier in our slide deck. So in our governance structure and what I've done in the past, our governance structure is comprised of physicians, hospitals, specialists, primary care providers, and whoever else is participating in our ACO that can influence the way we work, can lend their expertise to what we need to do and how we need to intervene in care. And underneath our governance structure, we have a series of committees that allow our network to provide further voice and expertise into our processes. A clinical integration committee that looks across the entire network how to manage a diabetic or CHF patient between the hospital, the specialist, the primary care provider, the post-acute provider. How do we standardize that? How do we do better with managing a chronic condition or a population of CHF patients across the full continuum. We have a continuum of care management committee. The continuum of care management committee looks at who's in our network, who do we want in our network, who don't we want in our network, how are we going to contract with them to be in our network, what are our expectations if they're going to be part of our network, because it's necessary to be clear about what your expectations are and what their expectations are if you're going to form a partnership to help support your population. Medical management and policy is a structure that allows us to measure our performance, understand how all the participants in our network are performing against some standardized benchmarks or performance targets that will help achieve the goals that we are looking to achieve over the coming years or next year. And then lastly, related to post-acute specifically, we have a post-acute collaborative. We pull our nursing homes together every month, every quarter, and we're transparent with our data. We put out the good, bad, and the ugly about the performance. We talk about the performance. We talk about what targets and benchmarks we can set. And then we look for quality improvement opportunities and share best practices within that collaborative. I found in my previous role at Cambridge Health Alliance, that was the most productive session for post-acute providers. They wanted to learn from each other. They wanted to understand how they were performing because they're penalized too if they don't manage the population appropriately. So they need to know where they're doing well and where they're not doing well. And you need to know that so that you can manage appropriately and generate the outcomes that you're expected to generate. And then none of this can occur without data. What Brian said and covered in his first couple of slides, the structure of the data, the magnitude of the data, it's more and more important that it's timely, it's relevant, you're able to act upon it, and you can use it to drive performance. If you don't have the data, you don't know what to focus on. You don't know where your opportunities are. You don't know what strategies or interventions can be used to improve your performance. And then lastly, you need the expertise and aligned workforce. You can't do this without the right people and the right skill sets within your ACO to be able to manage this. It does you no good to put a post-acute strategy in place if you don't have a care management team or transitions of care team or someone that can lead the post-acute strategy clinically to understand what's actually happening in nursing homes and how to manage patients and their length of stay within particular nursing homes. So you need to make sure that whatever strategy you have is informed by your data and your performance, and your data and performance also informs the type of workforce that you need to support that strategy. Next slide. So just to give you a couple of examples of how we evaluate and select our nursing homes to participate in our network, this is our facility selection grid. It's first used to understand how do we rank certain facilities that we may want to participate in our network. Now, I'm not going to go through all of this, but one of the measures is quality rating and readmissions. You can read all this and see how things are scored. It's a little bit subjective, but some of it's objective because we do look at the quality star ratings and some of the external data that we've gotten from PointRight. So it becomes a useful tool for understanding who do we think are really good partners to pull into our network and consider as a preferred part of our network. Next slide. So it doesn't do any good to do that, but then not manage the network and look at how they perform. So you can do an evaluation, but more than likely you're going to be wrong in some places. They're going to do better or worse. Maybe they weren't as good as you thought they were. But if you don't do an annual evaluation to understand that, then you can't possibly react to it. You can't talk to them about where they need to improve. So we use an annual evaluation grid to go through and evaluate the competencies and did they perform in the way we expected. We also put in place, as part of this annual evaluation process, a collaborative agreement with our post-acute nursing homes so that they understand what the expectations are. They know we're going to be doing this and we're going to be talking to them about how they've performed. And they also understand what we're going to do. We're going to provide them the information. We're going to provide them the tools. We're going to talk to them. We're going to partner and collaborate. And as long as you can do that all in a positive way and have the right outcomes, then we'll continue to have you in our network. But I found these two tools to be very useful in evaluating our nursing homes and using the data supplied by PointRight to help inform this process and continue an ongoing conversation with our nursing homes. Next slide. Thank you. So I think I'm back to Brian
Or Sean.
or Sean.
Well, I'll
Thanks,
take a stab at
everyone.
it. Go ahead, Sean.
Thanks. We have a bunch of questions coming in. So the first one, Sharon, is for you. What's the time difference between CMS data and PointRight data, especially since the SNFs are submitting data to CMS?
Sure. So a couple things. So CMS is typically, it can be a good quarter behind. Right now, skilled nursing centers are also submitting COVID-related data up through CMS into the CDC, and we get that file monthly. So we can, and that's actually included in that phase one, the scorecard, we have that in there now. But the MDS is, as soon as the MDS is, so typically within a couple of days that the patient arrives in the building, that first assessment, and that assessment is about 53 or so pages long. It's extremely comprehensive, and you want a couple of days to let each of the disciplines get in and really assess the patient and start getting their care plan put together. And then there are frequent updates through the MDS, and there's always an MDS completed if a patient goes back to the hospital or goes home or they expire. So you can get some, you can see at the beginning, middle, and towards the end of their stay, if you will.
Got it. Next question we have is for Lisa. Lisa, have you started to expand your post-acute network from SNFs to home care? And if not, when do you anticipate that happening, or when do you know when to be ready to select home care?
Yeah, I think that's a great question because post-acute is broader than SNFs. I can tell you from my experience at Cambridge, we immediately were looking at visiting nurses associations simultaneously with SNFs for a couple of reasons, because we were in a Medicaid arrangement and we really needed to understand the home health space. So it took us a year actually to work through home health. I think the information that's available for home health is far less than what you see for SNFs. They also don't have the depth of technology and data at their fingertips. So it took a while for us to build the infrastructure to understand, first of all, who are all the home health agencies that were touching our patients, and of those home health agencies, what skill sets did they have? How good were they? Could they manage the population? We started off at Cambridge with 10 visiting nursing association, visiting nursing home health agencies working with our patients, and we narrowed that down in a period of a year to 3. And by the time I left, we were looking at 1 or 2 because we needed the relationship with our providers. They didn't want to be dealing with multiple home health agencies. They wanted to be able to manage the communication with a consistent body of people, and we were able to do that. But it took a year to do that. At SOHO, we're just starting that with home health, and we're fortunate that within our network we happen to have an owned home health agency through Trinity Health in New England, which gives us a bit of a leg up in terms of how best to manage the population. But that doesn't mean that that's the only home health agency that's touching our patients. So we have a lot of work to do in that space, and that will be done over the next year.
Great. I'd like to ask Brian a quick question, then we have a couple more for you, Sharon and Lisa. Brian, how do you collect and standardize data when you're getting it from multiple places or systems in a network?
Yeah, so great question. So as you look at the evolution of different health systems and organizations, really looking at, the difference between, an Excel output from a different a data system versus some of the direct feeds you may get from, some of these national programs. So where we've been successful is really leveraging some of the data warehousing capabilities, where if we're able to take an Excel output from an EHR system or a financial system of record and actually enter that and upload that essentially into, or put a direct feed into a data warehouse, it really allows you to do some really cool things. So typically, when health systems have a lot of data, so you're looking at single Excel sheets, but when you can start to layer that information on top of each other, for example, you may have population health data in a given geographic area. You may have separately data on social determinants of health. So looking at those separately on a spreadsheet you need some analytics folks to help figure out, what's the full story there. But as you start to load that into a data warehouse, then you can start to look at, do social determinants of health impact some of the population health data, but also look at bringing other data feeds too. So say you wanted to also essentially pipe in COVID data by zip code from Johns Hopkins, you can layer on, is COVID having an impact in areas where, from a population health perspective, there's higher rates of, obesity, hypertension, or respiratory symptoms, and or either poorer areas. So you'd be able to look at multiple streams of data really kind of together. That's where we're moving from, looking at data sources to true insights as you're taking these outputs, regardless of the type of output you're getting from a system, again, whether it's a direct feed or an Excel file or whatever, having a standardized methodology that normalizes the data into a cloud-based architecture. But once it's there, you can do some really cool things in regards to putting different data sets together to really get some powerful insights to drive your business.
Great, thank you. And Sharon and Lisa, a couple more questions for you. For tracking and reporting performance of your post-acute care collaborative, did you build a dashboard? And if so, are the PACC members uploading data in conjunction with your institution?
Yeah.
No, so at
Sharon to start?
Yeah, go ahead. So the MDS is completed at the Skilled Nursing Center, and right through their EHR, they hit a button and it comes over to PointRight. And so then we apply our analytics and convert that into a visual. So there's a dashboard, if you will, that looks at facility level performance by those KPIs that are chosen, whether it's rehospitalization by clinical condition, length of stay by clinical condition. It gives staffing information. There's a breadth of data that's collected, but it's organized visually. And as Lisa mentioned before, during their collaborative meetings, when everybody comes together, that information is then shared. So it's extremely transparent. Lisa, anything to add to that?
No, Sharon, I think that's right. And the dashboards in PointRight are great for individual conversations with facilities, but also in a collaborative session looking at overall performance. We supplemented at Cambridge, that dashboard with our claims data so that we could look at utilization per thousand for SNF visits, the admits overall, length of stay, the cost per SNF, and then readmission rates and a few other key statistics. And that allowed us to focus even further on high performing facilities within our network versus lower performing facilities, because we got to see the PointRight data that could tell us, well, the CHF care wasn't maybe as good at this one facility, but much better at this other facility. But then we could go back and look at our PM spend and length of stay and see those improvements confirmed in the outcomes on the financial and utilization side. So the dashboards took a while to build. We ended up importing data from PointRight into our data warehouse to be able to consolidate some of it. But the PointRight data and dashboards are really, really good for the baseline understanding of the strengths and weaknesses of the homes in your network and for having specific conversations with your homes.
Got it. And another question for both of you, then I'm going to have a question for all three of you. Sharon and Lisa, how do the SNFs feel about PointRight sharing data with health systems, ACO, CINs? What's the value for them?
Yeah, well, I can give you my top four, and then Lisa, maybe you can add in some others. I would say initially, there's a period where you have to get comfortable being uncomfortable because the outcomes and performance outcomes of your center are being shared. And many of you that are sharing physician performance, it's the same kind of thing. You kind of get over that hump and embrace the transparency. Once that happens, though, what's amazing is best practice sharing starts to happen, and then there's conversation and insights to access to resources that the skilled facility may not be able to do on their own, that the ACO or the health system is able to supplement. Maybe if there's a high level of patients returning to the hospital because of pain, well, maybe there's a pharmacy consultant that can go in and help do some education. So there's the ability to tap into resources that they may not typically have. They start to see the value. Thirdly, I'd say it gives the nursing facilities the ability to tell their story, and hone in on where they're doing well and start working on the things that they need to work on. You can't be amazing at all things. So it helps them from a business perspective to figure out where should we invest our resources to become a center of excellence around X, right? And then lastly, sharing those improvements out to other referral sources is a way for them to, obviously right now more important than any, to keep their beds full. So Lisa, any additions that
Yeah, no, I think you summarized it right. I wouldn't, if you're going to utilize this data, I wouldn't start with the first, full-blown show everybody else's data. We started off with individual meetings with the homes to review their data, talk through their data, and then, warn them ahead of time that we were going to be sharing it broadly in a collaborative session. And it is interesting how the conversations evolve. You do begin to learn what the strengths and weaknesses are in various homes, and you also understand where they have what are their pain points. I'll give you two examples. We had one home that was really horrible on a lot of the quality metrics and on costs, had constant readmissions, and it turned out that one home had a large proportion of behavioral health and substance use patients. You can't expect a home to have perfect scores when you're managing a population like that. We also found that they didn't have the physician resources to manage the population within their home. So we were able to have a conversation around, well, what kind of resources do you need? Who can we bring in to help you? And what would that do? And that helped bring that nursing home scores up. They were still a little bit lower than the rest of the nursing homes, but it gave us an opportunity to have a partnership conversation around how can we help you. And then similarly, we had a couple of nursing homes that weren't doing well with COPD patients, constant trips back and forth to the ED, only to find out that they didn't have a way to manage COPD exacerbations in a nursing home. And we developed a rescue pack program for COPD patients. And that helped manage the COPD population in those nursing homes. And that was backed up with pulmonary resources and consultations when needed. So, they want to do better. They all want to perform well and do really great on quality, just like we all want to do. It's just that they don't have the observations that we have, like we don't have the observations at times to how our quality is perceived. And so the conversations are helpful from that perspective. And the last thing I would say is that this whole relationship in providing data and sharing data is ultimately needs to be driven with the outcome of improving patient care first and foremost. It's not good for patients to have readmissions. It's not good for them to be in and out of nursing homes. It's not good for them to get poor care on either side. So it's easier to approach these situations when you approach it from the perspective of the patient and trying to resolve the issues with the patient, rather than using the data to point fingers at why either party isn't doing well in the relationship.
Got it. Question for all three of you, and Brian, let's start with you. Do you all provide benchmarks and performance targets to your SNF partners? And if so, what metrics do you focus on?
So as far as, so Guidehouse is kind of in an interesting space. So we do a lot of support across the federal healthcare system, again, which is a little bit different than commercial markets. So, we're doing, support to, sites throughout the VA and the military health system. So we have federal healthcare data in regards to those facilities there, but we also have a number of kind of commercial healthcare partners. There's kind of sharing agreements in terms of client to client, in terms of what we are and are allowed to share it in between clients, but at the same time, we're allowed to give kind of some guidance in regards to, like hospitals and similar markets, and really helping them come up with kind of reasonable goals, reasonable expectations in their developments of their CIN, ACOs, in terms of where do you want to be from, revenue perspective and outcome perspective, and how you're actually managing your hospitals. I would say that there's definitely a push on the federal side to really be light and compared to a lot of the high performing facilities on the commercial side. So we're definitely seeing, as the data becomes more transparent, kind of to Leisha and Sharon's point, it becomes easier to start to share metrics, share benchmarks, and really begin to kind of have a group optimization as you go through together. So interesting space. We're in a little bit different position, I think, to share that information, but we're definitely going there as the data transparency becomes more popular.
Yeah, Brian, in addition to that, I would say from my perspective on the provider side, there's not a lot of benchmarks that are publicly available for how to do this. So we've often used improve upon our past as an approach. To the extent that we're in a network and we're participating in CMS programs, we can glean a little bit in terms of overall SNP utilization and spend. But when you get to the granularity of how is a particular home performing on a congestive heart failure patient, there really isn't the data to measure that other than looking through PointRight, which is the quickest way to actually get access to the data. There's no other publicly reported source for that or organized source of that information. So I would say the best place to start is start with where you are and look to improve upon where you are and look at who's a better performing organization in your network and who's a worse performing, and try to understand the differences between the two to see if the network can move closer to, in the aggregate, to the better performing nursing home. And at Cambridge, we saw significant improvements after a couple of years with working with our nursing homes, significant reductions in length of stay and in reductions in our post-acute spend and readmissions. And we saw the benefit through our value-based purchasing arrangements, and we saw the benefit in our value-based contracts.
So for the post-acute side, there's a few areas. So there you can look at the median of performance in a geographical market, right? And then we have over 2,700 SNF clients that we support every single day and helping them on their quality improvement, whether they're in a network or not. So there's this PointRight nation, if you will, benchmarking that. And then you can also look at state benchmarks as well as national benchmarks. The other thing that's unique and we'd love to see expand is the first one we did was in Maryland, where we have 30 hospitals that are at different points of the journey around these network development tactics. And they wanted to understand a little bit more about what others and their peers were doing. So we created this peer-to-peer, summit kind of environment. And they meet every quarter and look for ways and are benchmarking against themselves and looking for ways across the state and bringing in state stakeholders to find additional ways to support, as well as with the skilled nursing centers that are participating in these networks. So I would like to see that expand for other states to, as Lisa said, hook up with your peers, and there's so much learning that you can do between each other.
Great. Well, we're coming up on 2 o'clock, so I'd just like to ask any final thoughts that each of you would like to impart on the audience, key takeaways. Brian, anything you'd like to impart, and then Lisa and Sharon?
Yeah, so I think I kind of go back to the data piece. So really figuring out, what you need to do to move from, having kind of disparate data sources and really getting your arms around turning the data into true insight and allowing your actions to be truly data-driven as you go forward is really the biggest takeaway, I think, to make any of the ACOs successful. Yeah,
and so I would comment that don't give up, right? You will stumble at times, and a restart is okay. And stepping back and really leveraging your resources. We love working in this space, so leverage all of us and have some fun along the way, and celebrate as you hit some of those key milestones. It's really important for all.
I think that's important, Sharon. And the one thing that I would say is recognize it doesn't happen overnight. The strategies we're talking about, don't beat yourself up if it's taken a year. It will take a year. No two ACOs are the same. The complexities are very different. What works for one ACO may not work for another ACO, and you need to recognize that. And the time to put in a post-acute strategy is worth it, but it will take you a solid year or plus, depending on how big your network is and the complexity of your network. So don't feel like you're not making improvements. Use the opportunity to look back at where you were and where you are. And don't look, you need to look at performance data in that way, but also look at what you've put in place, because the performance data is going to lag so much further than what you think it will. The strategies you put in place today in an alternative payment arrangement you're not going to feel for 12 to 18 months later. There are some you can feel sooner, but post-acute is one that takes a little bit of time for you to see the material returns in your metrics. So be patient and don't beat yourself up if it's taken a little bit for it to actually show the results.
Great. Well, we are just about out of time. I want to say thank you so much to our speakers, Sharon, Lisa, and Brian, for joining us today. Thank you to our sponsors, PointRight and Guidehouse, for making today's session possible. And thanks to all of you for joining us today on the line. Just a reminder, the webinar has been recorded. You'll receive an email with a link to the video so that you can view it again. To access additional webinars or get info on how your organization can speak or sponsor, please visit wcwebed.com. Thanks again for joining us today. Have a great day. And this now concludes today's discussion.